And so when we look at these 926 patients and try to identify them into low-risk populations using various definitions, on the far left, we look at the molecular 7-gene biosignature applied to these 926 patients, and 38% of them would be defined as low risk with a decision score less than or equal to 2.8. In the middle, we use the RTOG 9804-like criteria, and 51% of the same patients would be defined as low risk. And on the far right, we look at the Memorial Sloan Kettering nomogram applied to these 926 patients, and we see that only 34% of them are defined as low risk. As I mentioned previously, of the 926 patients, 34% of them were identified as low risk using the Memorial criteria. When we look at their 10-year rate of local recurrence, despite being identified as low risk, at 10 years, there was a trend towards benefit from radiation, with about a 50% relative reduction in the risk of local recurrence. But now if we focus on these 320 patients defined as low risk with the biosignature and apply the 7-gene biosignature, we see that 63% of them, or 202, are now defined as high risk with a decision score greater than 2.8. When we look at the 10-year outcome in these 202 patients identified as high risk with the biosignature, we see a statistically significant benefit in the risk of local recurrence at 10 years with radiation therapy. So again, these are Memorial Sloan Kettering identified as low risk, 63% reclassified as high risk with the biosignature, and they showed a pretty dramatic reduction in the risk of local recurrence with radiation therapy. Looking at the low risk criteria patients, molecular low risk, we can see again at 10 years, there was no significant benefit from radiation therapy in these groups of patients.